Women's health. So the agenda today, what we'll be going over, we will we will talk about NAHSE mission and vision, panel introduction, and then we'll get into our fireside chat. Then following that will be questions and answers. Okay. So NAHSE mission and vision, the National Association of Health Service Executives is a nonprofit association of Black healthcare executives founded in 1968 for the purpose of promoting the advancement and development of Black healthcare leaders and evaluating the quality of healthcare services rendered to minority and underserved communities. NAHSE purpose is to ensure greater participation of our minority groups in the healthcare field. Its basic objective is to develop and maintain a strong, viable national body of more effectively to have input in the national healthcare delivery system. It has provided a vehicle of Blacks to effectively participate in the design, direction, and delivery of quality healthcare for all people. Today's event will discuss Today's events will discuss the fireside chat will discuss the breast cancer, maternal health, and mental health, which are disparities uniquely affecting African American women. You will hear from my experts' voices and walk away with empowering, actual insights that could change lives. So I want to get started with each of the panel members to give a brief introduction of themselves, starting with Dr. Oben.
Hi, can you all hear me?
Yes, we can hear you, Dr.
Okay.
Oben.
Yes. My name's Ima Oben. I am a maternal fetal medicine specialist. I practice in Houston currently, and I'm very much passionate about maternal health, of course, and specifically Black maternal health. I'm a mom of two. I love, love, love my kids. It's like my job that I wish I got paid for, but I'm grateful I don't get paid for because I might quit at some point. But ultimately, love being able to empower women, and empower women about their health, especially Black women. So that's a little bit about me.
Hello, all. My name is Sierra Barnes. I am a licensed counselor in South Carolina, so that is the state I'm licensed in. I was a school counselor for 12 years before transitioning into private practice. And so I also work as an adjunct professor at Liberty University in the counselor education department. And I've been doing that for 5 years, and it is a pleasure to be here.
Miss Allen, feel free to introduce yourself.
Oh, I thought we were going in the order. I apologize. My name is Colleen Allen. I am the Vice President of Sisters Network Incorporated. We are a national Black breast cancer organization, and we are headquartered here in Houston, Texas. And I look forward to sharing a little bit more information about my role with the organization and the impact that we're making nationwide.
Hi, sorry, I can go. I'm running in, so I apologize for being a little winded. I'm Veronica Jones. I am a breast cancer surgeon. I am an associate professor, so I also do research, and I'm chief of the Division of Breast Surgery at City of Hope in California. But I'm happy to be here with you all.
And we're so happy to have you. Hello, everyone. My name is Beverly Intagu. I work as a marketing and communications coordinator at Manifest MedX, a member of the NAHSE Health Policy Committee, and a member of the Executive Mentorship Program. And I am excited to help moderate this conversation. And since we have a lot to unpack in this short amount of time, let's begin by level setting for the audience. Can each of you, in no particular order, share why your area of focus is critical to Black women's health, and what are some common misconceptions that you've encountered in your work?
I'll start. As far as from Sisters Network's lens, as you know, and we'll go over a little bit about breast health statistics. But Sisters Network has been around since 1994, and Black women are disproportionately dying of breast cancer. Unfortunately, even younger and younger as we speak. We're getting calls, we get over 3,000 calls a year, and we're getting calls from young women 25, 30 that are being diagnosed, some that are not being turned away from doctors because they don't think that they need to have a further testing, et cetera. And so our impact in the work is important because we've got to save our sisters' lives.
Love it. I would say for counseling, it is very important to kind of address the stigma that's amongst the African American community about, hey, what happens in our house stays in our house. You don't go out here telling people our business. So, kind of addressing that and just kind of removing that stigma to allow individuals to understand that when we do speak about certain things that are happening, especially in our homes or, internally, those are things that we kind of overlook sometimes, but just knowing that it's important to just have someone to talk to is going to be important. Just kind of touching close to home, one of my little cousins, she just died by suicide 2 weeks ago. And just not knowing that she was struggling with anything is just kind of mind blowing. And just, you know, talking to the family about, hey guys, if you just need someone to talk to, just reminding them that it's okay to reach out for help and just giving them access to resources like, hey, star 988, or, just call someone. And so I would just say that's the reason why it's most important to just kind of, get it out there that it is okay to talk about things that's happening.
I would say for me, I think most of us know this stat. We quote it probably every day to some of our patients, but Black women are 3 times more likely to die from a pregnancy-related death compared to their white counterparts. And it's not just about the death, right? Because yes, that's definitely significant, but we're even also about 3 times more likely to suffer from a maternal morbidity cause, so like bleeding or additional surgery or something else that doesn't necessarily lead to a maternal death, but something that really can have a significant impact on our lives. And so that's why for me it's important to have this conversation around that and to continue to educate our sisters, our daughters, our friends about the impacts of that. I think a common misconception in the world of maternal medicine is about, and surrounding Black women, is that Black women don't speak up. I think that oftentimes people think that the reason why these mortality and morbidity events are happening is because these women aren't speaking up. But I think that's a very big misconception because they are speaking up. I think the difference is that um, they're just not being heard.
No, thank you all for sharing. Dr. Jones, did you want to add anything?
No, I agree with all of those things. And to Sierra, I'm really sorry to hear about your family loss. That's devastating. So I think I was just kind of pausing after hearing that. So I'm really sorry. Um, I want to echo all of those comments. I do believe that a lot of my patients, when they come to me, like they haven't been heard. They've been saying that they had, pain or a lump, and it's been dismissed as like you're too young, or um, or that's not what you think it is. I want to say that I know that we'll get to this later, but quick, just if you remember nothing else that I say, if you have a lump, you need an ultrasound. I mean, I say that every time I talk somewhere, so I'm just going to get it out early in this talk, because I think a lot of women, women of multiple ethnicities have dense breast tissue and they feel something and they get a mammogram and nothing's seen and then it's dismissed. And that is a common pattern that I see. And so I just want to put it out there that if you feel a lump and your mammogram is clear, advocate for an ultrasound. Ultrasounds are for lumps. So just want to throw that out there real early in the talk. But yeah, I just want to echo everything that everybody said. We're not being heard is enough.
Thank you. Thank you all for sharing. It's very interesting to see how these are misconceptions that, as a young woman, I've heard growing up and that older women have heard as well. And I kind of want to pivot to VP Allen and Dr. Jones in regards to breast cancer. What are practical ways to break down these misconceptions? Because, technology nowadays, everyone has access to everything, but not everything is always true. Whether it's going to social media immediately, TikTok is everyone's on TikTok and scrolling and Googling questions instead of asking maybe their provider or someone who's trained in that area that they're looking to get answers from. So, what advice would you have for us in this room and, for us to share with our family members to practically break down these misconceptions to save lives earlier, to intervene earlier?
I'm having trouble like getting on and off mute, so I apologize for that. Um, if I could really quickly, I think that P. Allen mentioned it earlier about like young women getting breast cancer. And I think some common misconceptions that I hear are either that young women don't get breast cancer, but it is on the rise. I think that was published in ACS's most recent report that the incidence of breast cancer is on the rise in younger women. But then also, I wanted to address this like family dynamic in terms of, well, no one in my family has breast cancer, and I find that to be a barrier among all people, and just kind of like recognizing that it's most 95% of the time it's not from a genetic mutation. And so that's a misconception, I think, among providers, that, well, no one in their family had breast cancer. It can't be that, and then not worked up, or even people themselves thinking, well, no one in my family has it. It's probably not that, and maybe delaying getting treatment or seen for something that is different in your breast. So I would just kind of break down that one. I would love to plug for everyone to kind of know their risk of breast cancer. By age 25, you should know what your risk is, and how you're followed by your provider should be tailored to your risk as much as possible. So to have those conversations early with your primary care, with your OB, with whoever's seeing you regularly, to just know what your risk is. So to kind of combat that misconception that because of X, you can't get it. So.
Miss Allen, did you want to add anything?
I'd like to maybe start on my presentation, and I think that would help shape the conversation. If you could first share about Sisters Network, that would be helpful, if you don't mind. So as I mentioned, Sisters Network is a national Black breast cancer survivorship organization. We're headquartered in Houston, Texas, and just want to tell you a little bit more about what we do, why we do it, and how we do it. So we are the only national Black breast cancer organization to have survivor-run chapters. We have over 25 survivor-run chapters around the country. We were founded 30 years ago in 1994, so last year was our 30th anniversary. And you can see on the map that's on this screen, we're very heavy on the East Coast. We've had chapters on the West Coast, but sometimes we lose a chapter because they are survivor run. And so, you know, the leadership, for a myriad of reasons, they're not well, or some ladies that just don't have the capacity to step up when some leadership has to step down. So we do lose a chapter. But from a national level, we provide financial support to survivors who are in active treatment through our breast cancer assistance program, which is named after Karen E. Jackson, who you see on the screen. She is the founder and CEO. She's a four-time 31-year breast cancer survivor, and she started the organization in 1994 because she found a void in at that time, the materials weren't like culturally sensitive, and believe it or not, the prosthesis, if you were a Black woman, they weren't brown. So just those different things. And so she found in even the support groups that they weren't really addressing. I think someone mentioned even with on the mental health side about talking about within our family, I think they mentioned, don't go telling your business and that type of thing. And so our slogan is stop the silence because if we don't talk about it within our family and share our family history, and I've had an aunt who died of breast cancer and nobody knew until the burial and that she had no breast. And what a terrible thing to die in that manner. So we provide financial support through the Karen E. Jackson Breast Cancer Assistance Program. It's national. We pay towards rent, mortgage, and utilities like electric, gas, etc. And then we also have an early detection component to that program where we pay for 3D mammograms and we partner with different facilities around the country. And then we have a lot of key programming, like we'll be hosting our National Black Breast Cancer Summit in Houston. It's the only one in the country. It'll be the first weekend of October. It's free, and I encourage you to share information about it. And we can get it to you all so that you can be aware of it. We'll have a very esteemed different medical experts who will be presenting. And Dr. Jones, I had recently found your information. I have not reached out to you, but I wanted to get to know you a little bit better. So I will be reaching out to you just to introduce more about Sisters Network. Um, but anyway, so that's a big program for us. Our Stop the Silence Walk in April is held during Minority Health Awareness Month, and so it's the only national Black breast cancer walk. We have over 4,000 women, men, children who come around the country to Houston for this walk. Portion of those funds help fund the BCAP, the Breast Cancer Assistance Program. To speak to the statistics that I'll go into in a moment about Black women and breast cancer, because we're seeing so many young women calling our office and being diagnosed, we have a program called the Young Survivors Initiative. And one of the programs is called Take Care of You Sis. And we launched a brunch and breast health series where we went to um, was it DC, LA, New York, um, Atlanta, and Houston. And we held brunches for 50 young women under 40, non-diagnosed, to have a conversation about breast health in general. And then we sourced medical experts in those key cities to come with no PowerPoint, but just to talk about breast health in general. Most of these young women have never had a one-on-one conversation with a medical expert that looks like them in their community. So it was an opportunity for us to introduce someone in their community to them, allow them to have a conversation about breast health on a high level. Most of them didn't know that if you're under 40, you're actually under 35, you're 3 times more likely to be diagnosed. I mean, 2 times more likely to be diagnosed and 3 times more likely to die of breast cancer as compared to their white counterpart. And so that was alarming to a lot of them. And so we wanted to start that conversation to normalize it. And the reason we said no PowerPoint was because we didn't want to, like, quote unquote spook them. We wanted enough just to have that conversation. Then we partnered with some beauty brands, Black Girl Vitamins, Miel, and so I mean, they got some great beauty. Amika, they came out of there with some good swag. But to make it fun, but at the same time very educational, and they walk away armed with some information. And so it was a very successful program. So we're always doing things that are going to be impactful. And this, where it says key programs, that's a list of the myriad of different programs that we do, and I won't go into all of them, but we're out there, we're on the front line. We have been since 1994. We're not going away. We're here for our sisters. And we just encourage everyone to get their mammograms, because early detection is definitely not a slogan. Mrs. Jackson, on her last diagnosis in 2019, she says she gets a sensation in her body. She went for her mammogram at MD Anderson, was clear. She got an ultrasound, it was clear. She still felt the sensation, pushed for an MRI, and she found it. So that's, again, knowing your body. It's so important. Like Dr. Jones said, if you have a lump, and we've had women who call us and say, I have a lump, and they said they want to watch it. Watch it for what? You need to have an ultrasound. You need to have a 3D mammogram. If 3D is the latest, greatest that's what you have to do. That's what you should be getting. And so when we partner with facilities for our mammogram program, we will only partner with facilities that will give 3D mammograms. We will not pay for, Mrs. Jackson's like, that's the best that I want for myself. I want that for the women that we're supporting. And so that's a little bit about us. If you want to go to the slide with um, some statistics, we have a lot of resources on our website, and I'll talk about a little bit on the statistics. Black women, can you bring that up? I think she's trying to bring it up. Excuse me. So you'll see these are the facts and Black women breast cancer facts and figures. You'll find this on our website. It's a one-pager downloadable, and we have a lot of different, we have signs and symptoms. We have a lot of different brochures that people can download for community events, etc. So in 2025, these and this is according to American Cancer Society facts and figures. In 2025, about 6,170 breast cancer deaths are expected to occur among Black women. Under 35, as I mentioned, Black women are 2 times the rate of white women to be diagnosed and 3 times more likely to die. Usually, we're getting more aggressive breast cancer, like triple negative, and you'll see in the statistics we're 1 in 5 cases of Black women as compared to 1 in 10 in other ethnic groups. About 12% of Black women will be diagnosed during their lifetime. Our survival rate is still 10% below compared to white women. And Black breast cancer is still continues to be the most common cancer among Black women. As far as we're concerned, we have a breast cancer crisis in the Black community. When you have this, and we coined that in 2021, we had a state of state of the Black breast cancer crisis, a town hall, and a call to action because we felt like no one was saying it. We know it. The statistics are there. They're not changing. So, we felt it was our responsibility. And there are some smaller Black organizations that are coming up that are breast cancer oriented, but I don't think some of them would feel as comfortable. We've been around long enough that we didn't mind taking the hit because it's not popular to say certain things that people don't want to hear. But when we have this many sisters dying, that is a crisis where we come from. And so we're ringing the alarm, we're sounding the alarm to let our sisters know that they have got to be proactive and advocate for themselves because your life depends on it. And if you've been on TikTok lately, you will see so many young Black women on there chronicling their breast cancer journey. It's alarming. It is alarming. And if you, I don't know how many of you heard about Ananda Lewis, who was on BET back in the day as a VJ, who said that she stopped her treatment. She passed away today. It was just announced about an hour and a half ago. And she decided to go the holistic route. And then once that didn't work for her, when she went back, I'm so sorry. When she went back to go ahead and get traditional treatment, she advanced to stage 4, and unfortunately, she passed away today. So, our message is strong is that we want to be a resource for the Black women in the community. We are here. You can go to Sisters Network, inc.org, or just Google Sisters Network will be the first. You just say Black women and breast cancer, and we'll be the first organization that comes up. But we are here to serve the community, support our sisters. We have a fact sheet that's on there it says what to ask your doctor because we know when you are diagnosed, the gray matter comes out of your head for your caregiver, for the loved ones, for the actual person diagnosed. And so we want to arm our sisters with the most important information to ask your surgeon. What you ask your surgeon is not what you ask your oncologist. What you ask your oncologist is not what you ask your doctor for potential reconstruction. Every doctor has different questions that need to be asked. And so we try to arm you with that information so that you at least have some sort of guide to get the answers that you need to make the decisions that you need to make. And so again, we're here to serve, but I'm telling you now, and Dr. Jones will probably speak to it again, but we're getting it too young, and we're being turned away, and one of the things that Mrs. Jackson would like to see, and we're starting to do some policy work, is that we want to see the guidelines reduced to 35. We can do the advocacy work, the awareness, which is all important, but the real change comes at the policies at the state and the federal level to allow our women to have more access to screening at earlier ages. And if you follow how the statistics were, I mean, the access was it was at 50, they dropped it to 40. But and so people were applauding. And but as she reminded me, she says, well, if you know, it was 40 and they raised it to 50, which they never should have done. And so when they're dropping it to 40, people are happy, but you should have never took it to 50. She says, I can't get excited about that. Drop it to 35 and then you're doing something. So I've had to work with her on messaging so that we we can get what we need done. But she's very angry because she's like, I've been in this game too long. I've been around here 31 years as a survivor. I've seen it. You know, she was just awarded the ASCO Patient Advocate of the Year award, and that's by all the oncologists, you know, globally at the ASCO conference in Chicago a week and a half ago. So she's highly regarded, very outspoken, and she's very passionate that our sisters deserve better. So again, Sisters Network is a resource. We work very closely with a lot of medical experts. We don't work directly with Dr. Jones. Hopefully we'll develop a relationship with her, but many doctors around the country at different cancer centers. And if you are in a city with a major cancer center, you need to try to go there. You know, try to make sure you're getting the best care that you deserve. Advocate for yourself. So I thank you for giving us a platform to share a little bit about Sisters Network. And I wasn't familiar with your organization, but I'm very happy to learn about you guys. So anything that you need, please keep us in mind.
Thank you so much, Miss Allen, and thank you, Dr. Jones, for tearing the veil between what we may have known, what we didn't know from what you both have seen. I think the insight that you've shared really speak to what's happening on the ground, even down to the guidelines. I had no idea that it originally was at 40 and went up to 50. So to learn that information today and to hear that it should be even lower helps me advocate for those in my arena, for those on this call, and helps us to speak to the women in our family and even take care of our own health in a different way.
Let me just say really quickly, let's not forget about our brothers. Men get breast cancer too. And as you know, Matthew Knowles, Richard Roundtree, Shaft. So there are men, black men, white men get breast cancer. We like to call it chest cancer to just make it a little bit more palatable for them to, especially if they have a mother and it runs in their family, they are at risk. It's not as prevalent as for women, but it is a risk. And just yesterday, we got a call from a group of ladies in the Lufkin area. They want us to come and speak. There are two young boys that are brothers. I think they're twins. I think she said they were twins. She did say they were twins. 15 breast cancer. 15 years old. So we want to make sure that our brothers, who are sons of survivors, are familiar with their chest because they could be at risk and they don't even think about it. They think it's a woman's disease.
Thank you for that insight. I myself didn't know that, so thank you for sharing that. On the topic of mortality and risk, I would kind of want to switch gears to Dr. Oben to talk about maternal health and ask what are the major drivers of maternal mortality among Black women? And are there complications? You spoke earlier about complications outside of giving birth that can lead to mortality or to death. What are frequently overlooked and underestimated, and how can we jump ahead of that curve in our families?
I want to start by saying VP Allen and Dr. Jones, I think this is a hard one to follow. Thanks, Beverly. But thank you guys so much for the insight. I learned so much even for my own health and things to advocate for myself for, and I'm an OBGYN just to give you that perspective. So thank you guys. Thank you for these kinds of conversations. Switching gears to maternal mortality, some of those things that are really, really big, really the leading causes for maternal mortality, and especially surrounding Black maternal mortality, are things relating to cardiac disease, So like heart failure, heart abnormalities, most of which stem from hypertension and diabetes, so chronic illnesses. And then as well, we also have in that same realm with hypertension, things like preeclampsia, which is another big issue or big cause for morbidity when it comes to, especially in the postpartum period. Because oftentimes women think, okay, I'm done being pregnant, I've delivered, I've had a healthy pregnancy, and they fail to recognize some signs that may not feel right. Or even if they do recognize the signs, their providers don't always recognize those signs, causing either a late diagnosis or and therefore leading to a worse outcome. And then you always have the postpartum hemorrhage, the infection risk, and then we should not fail to realize that mental health and suicide and overdose are also on that list for our moms, especially in that postpartum period. So those are the big causes of maternal mortality and morbidity. I think some of the things that we can do to get in front of that or jump over that hurdle are number one, conversations like this, continuing to encourage our moms to reach out to, starting from where I ended, like our mental health providers, or if they have one, or referring patients to mental health providers who are also familiar with maternal health. So that's been a big one. Our hospital has a clinic for mental health, and they specialize specifically because it's the women's hospital. They specialize in maternal mental health, which is critical in those early days when you have a newborn and then you're overwhelmed with everything else that you already had in life before, the baby was here. Um, and I think a lot of this is about advocating for our friends, our patients, you know, and by that I usually tell my patients, like, if it doesn't feel right to you, go and talk to somebody. And if they don't listen, find somebody else who will. Go back to somebody else. Go on another shift. Find another ER physician that will listen. You will get to somebody, even though it shouldn't be that way. But if that's what you have to do to just be heard, don't stop until you feel like you were listened to. Um, and then the other one that I always close up with is telling or reminding my patients that, Black women genetically we're predisposed to a lot of things, right? We're more at risk for preeclampsia, we're more at risk for heart disease, even in women who don't have any diabetes or hypertension. So it's just important to make sure that as you're entering a pregnancy, you're doing that with as much preparation as you can. I think as moms, we're very big in pregnancy about eating right and doing the right thing and making the right choices and gaining the right amount of weight. And I think sometimes it's important to also go back and recognize that even before you get into that, let's work on your hypertension. Let's make sure your blood pressure is controlled before we go on to a pregnancy, which can put more mental, emotional, and physical stress on your body. So those are the things I really try to encourage, like a preconception visit, because I think that's really critical to recognize what medical problems somebody might have, and even if they don't, what is their risk and how can they decrease that risk, right? Is it that they need to find a provider that looks like them, or just start to have a relationship with a provider who will listen to you so that when and if you do have any complications in pregnancy, you don't feel like you have to talk to five different people first before somebody has actually listened to your concern and acted on it. So those are the main things that I would say.
Are there any guidelines, do you think, that have impacted your ability to give care or for patients to advocate for themselves in these situations?
Unfortunately, there's no specific guidelines. There's no published guidelines, let me put it that way. I think one thing that I do teach my learners is, and I tell, medical students and residents this all the time, even when I was in training. If you see a patient come back a second time around in that 24 to 48 hour period, please keep them. Because even if you don't know the reason why they're back, I promise it's not to bother you. It's not because they're bored. They have things to do. They're there because they actually need to be there. So if you can't figure it out, keep them overnight and let the next person with a clearer head on a new shift come back and figure out what is going on with that person and why they're there and how they can hear that concern and evaluate that concern. And even if nothing comes out of it, you've watched somebody for 48 hours. You've left them with peace of mind that in 2 days, nothing has changed about whatever they were feeling. So more than likely, they're probably okay. They will leave with a sense of peace of mind. But more importantly, you have listened to somebody who needed to be listened to. So no published guidelines, unfortunately, but just I think just conversations like this and conversations with our friends and our partners and our our daughters, our sisters, like, you know, so.
No, that's really good. Thank you. And even speaking of, family and friends, have you seen a difference in outcomes when it comes to different support systems? Like, have you had a family come in and support a patient and seen a different outcome? Have you seen a patient come in by themselves and not really have anyone behind them? Or do you think that has an ability or an impact on the questions they ask or how they're seen or what just happens from pre-pregnancy to post-pregnancy?
I think family support is absolutely crucial. I think I would not have made it where I am without my family. They really truly are my village. And even if it's just about raising kids or helping me raise my kids, but to go back to your question about seeing a change in outcome if the family is present, I definitely think that helps. And it's definitely a good support practice. Even if the family can't be there, I'll sometimes say, do you want to call your sister on the phone? Or like if they maybe were talking to somebody or it seems like they said like, oh, I told my sister and I sometimes I'll say like, do you want to call that person so that maybe I can hear that person has a better way of reporting the story to me and then it can give me some clues. So that family support helps. And I have definitely seen changes in patients where I can see where the family comes with them, they feel more at peace, or the family provides some background to things that we didn't think were related to the patient's history. Um, and the one case I can remember, I remember this patient who came in for, I think she came in for leg pain. Her legs weren't really swollen, but one of her legs she complained about being just being more painful. She's maybe about mid-trimester pregnant, so about 23 weeks pregnant. And then she came in the first time. I think she came by herself. I didn't see her. Then the second time she came in, and at that point I'm already thinking, oh, I'm probably gonna order an ultrasound. But then her exam didn't seem impressive. And so in your mind, sometimes, especially with your co-workers, they're like, why would you waste that resource? They're thinking that. You're like, you start second guessing yourself. Then, as we're talking about her history, which I had asked her about her family history, her mother's like, "Oh, but does this have anything to do with if you have a clot in your lungs? Because I've had two of those." And I'm like, "Whoa, whoa, 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 whoa." So, just to give you perspective that the in that first situation, right, you're looking at somebody who is has a benign exam and you're not potentially thinking maybe that this person has a clot in their leg because their exam is unremarkable. But when the family steps in and provides just a little bit of information which the patient, didn't know about, right? So it's again going back to the theme about stop the silence. Let's talk to our families about our history so that that patient should, it would be great if she had known because the first time hopefully somebody would have ordered evaluation. But she ended up with a clot in her leg. She's delivered now and everything was fine. But the point I'm trying to make is it obviously raised my suspicion a lot more when her mother said, "Oh, I've had a clot in my lung, so therefore there's something familial going on here."
Thank you for sharing that case. And I'm really happy that her mom was able to step in at the time that she did to share that. Oh, go ahead, Dr. Jones.
Can I just piggyback off of that? That was beautifully said. And I want to say that the same applies for breast cancer or really any cancer, and the family stepping in and providing that history is so critical. And I love what you shared, Dr. Open, about the just listening and advocating for patients to go back a second time and to be admitted at that point. This is beautiful. I wanted to highlight that. Um, and then also wanted to just say that the same is true for outcomes for breast cancer. So they have done studies on support networks for patients, and they found that patients with support networks actually have better outcomes and better survival. So it really extends into even cancer survival in terms of breaking that silence, bringing people in to form a village around you as you go through treatment. So.
Thank you. I agree. I think a recurring theme from what I'm hearing from all of you is having these conversations, speaking up, asking questions. And when you hear different diagnoses, turning over to you, Dr. Barnes, mental health is a big factor because your mind starts to race, what's going on, what's going to happen, what has happened, what have I learned, et cetera, et cetera. So I kind of want to hand it over to you and see if you have seen any implication of mental health across these disciplines. And I know you have a presentation to share with us. If you can kind of go into that to give us more insight into how mental health affects Black women in that way.
Okay, thank you. Do I need to pull it up on my end or?
No, we'll pull it up in 1 second.
Oh, okay. All right. So, as you guys can see, just trying to focus on the top mental health concerns seen amongst Black women today. So, according to research, it indicates that Black women face disproportionate rates of PTSD, and it's particularly related to experiences of racial discrimination and intergenerational trauma. Within the intergenerational trauma is usually connected to molestation in their early childhood, and they're processing through it as an adult. So that's one of the top ones that I see. Depression and anxiety rank amongst the most prevalent issues and is often exacerbated by unique stressors, including racial trauma, again, just connected to the PTSD, discrimination in healthcare settings, and the strong Black woman stereotype. And this is something that it can often discourage seeking help. All right, we can go to the next slide. All right. So when we're talking about stigmas, kind of, the same thing I mentioned earlier about, hey, what happens in here stays in here. That's one of the biggest things that we want to kind of move past. But just kind of reading through my slides so I don't get off topic. So stigma, particularly around mental health and certain medical conditions, can prevent individuals from seeking necessary care due to a fear of judgment or discrimination. Cultural expectations, including traditional healing practices, kind of going back to the breast cancer individual who was fighting through that as a survivor and then kind of changed up her approach to gender roles, family dynamics. So these may conflict with modern medical approaches, leading to delayed or refused treatment. Access barriers such as geographic location, transportation limitations, financial constraints, and language differences can make it challenging for individuals to receive timely and appropriate care. Healthcare providers must understand and address these interconnected barriers to deliver culturally competent care and improve healthcare outcomes for all populations. This includes developing strategies to reduce stigma, respect cultural beliefs, while ensuring medical safety and implementing solutions to improve healthcare accessibility through measures like telehealth, mobile clinics, and multilingual services. All right, so some advice for healthcare professionals working to support mental health, wellness, or mental wellness. The first thing is to prioritize active listening, kind of going back to what was stated earlier about just hearing your patients out when they're coming in and, making sure you're paying attention to certain things that are happening. So validate the patient experiences without judgment. Create a safe, confidential environment where individuals feel comfortable sharing their concerns, implement regular mental health screenings as part of routine care protocols, and develop clear referral pathways to mental health specialists when needed. Another is to practice cultural competency and recognize how diverse backgrounds influence mental health perspectives. Stay updated on evidence based mental health interventions and treatment options. Maintain professional boundaries while showing empathy and document mental health concerns thoroughly in the patient records. Engage in ongoing professional development focused on mental health topics, trauma informed care, and crisis intervention. Build a strong professional network of mental health resources and specialists for consultation and referrals. Consider implementing wellness programs, heavy on that, or support groups within your healthcare setting to promote mental health awareness and reduce stigma. All right, so one thing I wish every healthcare leader knew about mental health. So, mental health impacts every aspect of healthcare delivery, from patient outcomes to staff retention. By implementing trauma-informed approaches, fostering open dialogue about mental health, and providing comprehensive support systems, leaders can transform their organizations into spaces that truly promote holistic well-being. This shift requires moving beyond the traditional metrics and recognizing that investing in mental health infrastructure isn't just an ethical imperative, it's a strategic necessity for sustainable healthcare delivery. All right. So I won't read through all of these different levels, but just kind of give you a little oversight. Small, actionable steps to improve healthcare outcomes in our communities. So by implementing these steps systemically and collaboratively, communities can create sustainable improvements in public health outcomes. Success depends on consistent effort, community engagement, and regular evaluation of progress. So that's the most important part. So at the individual and family level, here are a few that can be done. One that stands out to me mostly is to share health resources and information through local social media groups. So you can kind of just glance at that list for individual and family level. The next is organizational level. One that stands out to me mostly is to advocate for workplace wellness programs. To me, that is so important because coming from a setting where it's like work, 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 and people are penalized for being off, you overhear conversations like, girl, she missed another day at work. And then somebody else is like, well, she kind of needed that time off, or being in a setting where your boss is saying, hey, you only get 3 days of bereavement, even though your mom just died. We expect you to be back at work in 3 days. So, just kind of advocating for that in the workplace would, be very beneficial. So this is a list here. You can look at that. And then lastly, at the policy level, one that stands out to me would be to engage in local government on health initiatives. So just kind of being a part of the conversations that can impact change would be very beneficial. But you can glance at this list and kind of look at those and kind of find ones that stands out to you as well. And then lastly, I'll just end with sharing my information, just in case you guys wanted to learn more about me and my private practice, or if you just need to kind of reach out for a brief free 15-minute consultation, you can scan this link here, and that is it. Thank you.
Thank you. Honestly, thank you all for sharing such powerful insight this evening. I do want to leave room for the audience to ask questions before we kind of start to round out. So if anyone has a question for any of our speakers, please, feel free to get off of mute. You can turn on your camera, or you can ask the question in the chat and I will read it out to them.
I have a question for Dr. Barnes. I'm curious to know what avenues you know of, and I don't know if this is something please feel free to just email me, and I can share my email, just avenues that I can provide to my patients who are seeking that maternal mental health resource that may be virtual, either like a conversation with you, setting up a counseling session with you. I scanned your QR code and I was just looking, amazing website, but
Thank you.
um, yeah, I was just curious to know how to achieve that. And also I don't know if you want us to share this, like if we can share that with our patients, things like that.
So I'm only licensed in South Carolina currently. So I'm not sure if you have patients in South Carolina, but if you do, yes, ma'am, please send them my information and we can kind of go from there.
Okay, thank you.
You're welcome.
All righty, I see a question for Dr. Jones. Could you speak to if the COVID-19 vaccine has any impact on breast cancer?
That is a great question. It is a great question. I will say that what we do know is that it absolutely has impacted the lymph node response, right? So after people were getting the COVID vaccines, we were seeing them in the office, and part of um, some patients' routine care is um, to get ultrasounds of their underarm area. And we were seeing that the COVID vaccine would really inflame the lymph nodes under the arm. And so it was really problematic when patients have had a history of breast cancer and all of a sudden the lymph nodes under their arm are big and suspicious looking again. So we actually had to institute new protocols for ultrasounds since the start of the COVID vaccination. So um, we have seen that patients have enlarged lymph nodes, and then we have to do ultrasounds more frequently. But I don't think that we have, well, I know that we don't have great data yet about how the COVID vaccine has impacted breast cancer incidence. Hopefully, that data will come out soon or in the future. But right now, we don't know. I don't think we know a lot about the COVID vaccine's impact on the immune system and inflammatory responses. I would love to hear uh, Dr. Oben's response actually to that question, because I know I've heard from my patients who also, I talk to about changes in their menstruation a lot, just because we give medicines that impact their cycles. So it's conversations that come up in my practice as well, but I want to hear her take on it, just to see how the COVID vaccine has impacted women in their maternal health. I want to know that. That's my question. Yeah.
So from our standpoint, we've definitely seen women complain or report more heavier, like changes in their cycle. So either a more irregular flow compared to, let's say, women who was always regular. We've also seen the extremes of amount. So we've seen heavier bleeding. We've also seen lighter bleeding. And then we've seen patients have more premenstrual symptoms as well, like cramps or pain or things like that. Most of the time, what we saw, at least up when COVID, all of this stuff started coming, has been more short-term changes. So definitely we've seen those changes, but not long-lasting changes. I know there's still a bunch of studies that are out there going on, funded by the NIH, on looking at like how the COVID vaccines have impacted these things. But that's the general idea of what we've seen.
Thank you. I believe we have a question from Princess. Would you like to come off of mute and ask your question?
Hi, everyone. My name is Princess. First and foremost, thank you all for this information. I'm not gonna lie, a lot of the stuff that I heard is a little bit scary, but like I like to be informed. And shout out to Beverly for introducing me to this meeting too. My question is, how soon or how early should I be like looking into things like that? Just for background story, like I'm 27. I don't want to have kids right now. I do not. However, I do know that that is something that I want to do in the future. And like I hear a lot of stories about, I'm in my late 20s. It's about time to start having kids. Like, I don't want to feel pressured into having kids. But I also know that like the older I get, there are chances of complications as well too. So I just want to know like when is like the right time to start doing all that background information, looking into like my health, like looking into what's going on in my body, so that when I do want to start having children, like, like I'm okay. You know what I mean?
Yeah, I think that's a very good question, Princess, and I think that's super insightful. And I'm sorry, you said you're 27 or 29? I can't remember.
27 by God's grace.
Okay. Um, and I think honestly, the time is now to start looking into those things. I'm not saying definitely if you're not ready for kids, the time for that is not now, but the time for looking into your health is now. And that's just like seeing your primary care provider. I think it amazes me sometimes how many patients, and I honestly don't know why I'm super surprised about it, because even if I poll my family and I ask my brother or my sister, when's the last time you saw your PCP? They're like, well, I don't have any problems. They're younger than me. They're like, I'm in my 20s. Why would I need to see a physician if I'm feeling well? And I think just a once a year visit to your primary care doctor or your OBGYN is enough. That person can check your lab to make sure you're not diabetic. That person can check your blood pressure. You can also do that if you go to any pharmacy, and then it can prompt potentially another appointment if you need one. But if all of those things are normal, you're good for a year, and you know that for the most part, when you do decide to become pregnant, your outcomes are more than likely going to be normal. That means like you will end up with a normal, healthy full-term delivery, given that you entered pregnancy already low risk. However, if any of those things are not, then making sure that they're all optimized before you do enter a pregnancy. And the other thing that I will add, I think this is a perfect time to develop a relationship with an OBGYN. Make that person your friend. Let it be like, hey girl, like let it be like that, so that when you come with anything, or if you do, that person, not just you trust them, you trust what they're saying because you developed a relationship with them. And even if you have to see them like once or twice a year, that's just enough time to just bond and develop a relationship with somebody who's going to be caring for you for about 40 weeks of your life. So that's what I would say.
Thank you so much.
You're welcome.
And I actually have a question for all the panelists. As many of us, and maybe not all of us, but the church plays a big role in Black households. I wanted to ask, how do you navigate conversing with patients who kind of, may respond, God's got me, I'm gonna be all right, no matter the diagnosis or even intake in conversations? How do you navigate those situations when it comes to maternal health, breast cancer, and mental health?
So for me, I actually had a client who was diagnosed with cancer. She didn't share what form, what type, because she felt like, hey, I just want to ignore the conversation because she felt like, hey, God has me. He's going to get me through this. I don't need to talk about it because if I talk about it, it becomes a reality. So with that, I decided to take on a therapeutic approach called acceptance and commitment therapy, where we focus on accepting the reality that's, put in front of us. Like, God has you, and we can look at the facts. And so with that, as a clinician, the first thing I'm like, hey, did you reach out to your doctor to kind of talk about, different types of interventions that could be used to help, versus only saying I'm going to pray my way through it, like, going to get chemo or taking medication, whatever that looks like. So we're working on it. We haven't gotten to the place where she's like fully, trying to, take the medication or going the route of receiving chemotherapy. So we're still working on it.
I love that language, Dr. Barnes. If you could email me that, that would be great. That sounds like a great framework. I would love to use that as a resource. It does come up in my conversations with patients. So, just for some background, I am a pastor's wife, and my husband started a church. Many of my patients know that about me. And so faith does come up in quite a lot of my conversations with patients. And we talk, quite frankly, a lot of my appointments are very long, about what's driving decision making in all arenas for a patient. Faith being one of them, a very important part of it, but there's several, there's usually lots of factors that contribute to a patient's decision making. And usually I do try to, I can bring in my faith in a lot of those conversations with patients. And I bring in my story and my witness and how I feel like God God using me in this capacity in their lives. And it's usually not a one-time conversation because cancer treatment is very involved and very long, and there's multiple components to it, right? Like many facets, like chemo and surgery and radiation and endocrine therapy. And it's kind of, it looks different for every patient at every point. But I think one approach that I take is just sharing a lot of, in a professional way, myself in there and having those faith conversations with my patients. And everyone's different. Every patient is different. Every patient lands differently. But if we could just get to like the root of their decision making and address it, then I find that helpful.
I think those are all very good ways. And yeah, I agree. I like the way you guys both put it, Dr. Barnes and Dr. Jones. And I think that personal aspect does help patients. My go-to statement is when they say God's got me, I'm like, I agree, he's got both of us, but let's see how we can support him. So let's do this. So let's help him so that we are all doing this together. And then they're like, oh, okay, all right, that's fine. I'll take my aspirin. I'm like, okay.
That is so good. Thank you all. That's really, really good. Um, as we are kind of winding down, are there any other questions before we close out? All right. Well, seeing none, I just want to say thank you, Dr. Jones, Dr. Oben, Dr. Barnes. Thank you for your time. Thank you for joining us. Thank you for teaching us, walking alongside us. Just thank you for the insight that you have shared this evening. I know a lot of us are leaving with a lot more information than we may have anticipated and can, to your point, break the silence and have these conversations with those around us. I also want to take the time to thank Delshawn and Zykeria, members of the Health Policy Committee, for putting this event together and coordinating everything, and for you all as attendees for being here, digesting all of this information. Thank you all so very much.
Before you close out, Beverly, I do not want to let this end without thanking you as far as being part of the Health Policy Committee, for moderating this event, for collaborating, help putting everything together. So thank you as well.
Anytime. I love this organization. And speaking of this organization, if you are not a member of NAHSE, please visit our website and join so that you don't miss key events like this. And for those who are members, the Health Policy Committee is always looking for new members, new ideas, new conversations. So please feel free to reach out to any of us to join the committee. And with that being said, I thank you all for your time. I hope you have a blessed rest of your day and Godspeed. Thank you.
Good night. Thank you.
Bye.